Before I am starting, I would like to thank IMA Bhimavaram for giving me this opportunity, and I would like to thank Imperial Hospital Management, especially Verma sir and Naresh sir, who are with me from the day one. And with this brief introduction, I am going to discuss my my main aim of this discussion is basically, so interventional radiology is a new upcoming branch where we are dealing with almost every system starting from head to toe, and my personal interests are oncology and body interventions. So I am going to give a small glimpse into every system where some of them are real emergencies and where some of them are electives, and how we would like to deal with them, and what is the exact role of interventional radiology in some of the disease conditions. So with this brief introduction, I am going to start my presentation. So basically IR, we used to call IR is interventional radiology. So IR is a subspecialty where we use image guidance, either CT or ultrasound or fluoroscopy, to deal with diagnosis or treatment. So most of our IR procedures are daycare procedures, and we used to done under local anesthesia, and most of the times the skin incision size will be very less, that is almost this is the size of the incision we used to give. So this is our overall areas of, like neuro, gastro, cardiovascular, chest and thoracic, gynec, oncology, renal, nephrology, urology, orthopedics, and these are the almost all systems we used to deal in specific conditions, either by embolization or ablations, or for the diagnosis purpose, or for angioplasties and stentings. These are some kind of procedures we used to do in routine. So we'll start with diagnosis. So normal biopsies, like nowadays regular, our regular radiologists are also doing, but some of the special situations where IR comes into a role. So especially in difficult access lesions, particularly very small lesions where the diagnosis is mandatory for the further plan of action, and this is some of the conditions I am showing. So this is the lung CT. So the size of the target is very less here, and this is another CT, mediastinal mass. So this is our needle, and this is another condition where some small para-aortic targets. So without any further complications, without any further injuries to major organs, we used to take samples. Some special conditions like transgastric biopsy, transsplenic biopsy, and so this is another one which we did in our fellowship. So this is a mass between portal vein and IVC. So we took the core from here, and this is the sample we got, and this is ultimately turned out to be a portal vein, IVC leiomyoma. So these are some special situations, and percutaneous bone biopsies, especially in bone tumors conditions or hematological conditions where true cut bone biopsy samples are needed. So these are the targeting images from percutaneous bone biopsy to avoid major surgeries. So another special entity, transjugular liver biopsy, especially in liver failure patients where anticoagulation, where doing open biopsy or percutaneous biopsy is difficult, especially failure of coagulation failure and massive ascites, post liver transplant patients. TGLB is one of the special entity where the diagnosis is mandatory. So we used to approach from IVC into hepatic vein, and we used to take the samples from liver sample. So this is one special condition, transjugular liver biopsy. So with this I am concluding diagnostic purpose. So yeah, almost any lesion, even small difficult access, we used to take samples without any further damage to adjacent organs and viscera to avoid major complications. So now next come to therapeutic part. So I am going to start with major common conditions like peripheral and endovascular. So in our territory, especially what I observe is peripheral vascular disease, one of the major common problem. So peripheral arterial disease, so we used to do SFA plasties and superficial femoral artery and below knee disease. So diabetes is one of the most common problem here, and when it combined with peripheral arterial disease, it's going to be a deadly combination. So until otherwise we improve the vascularity to the affected part, the wound won't heal. So now another common one is varicose veins. So it's a small, very common problem and at most neglected problem also. So varicose veins, routine conservative stockings, limb elevation, some venotropic drugs, these are the routine things. And apart from this, vein ablation therapies like laser therapies or radiofrequency ablation, and recent most advanced is one of the super glue therapy. These are some catheter based treatments for varicose veins, and everything is daycare procedure, and patient is going to home on the same day, and patient can resume his or her routine activities from the next day itself. So this is one condition. So this patient recurrent ulcers with SFJ significance reflex after post laser and 2-3 regular compression dressings, the wound got healed, and these are the some laser images. So peripheral angioplasty. So due to our lifestyle or our habits, our risk factors, comorbidity conditions like diabetes, hypertension, and the peripheral arterial disease is very common in our territory. So most of the patients after 60s turned out landing into below knee disease, where ATA, below knee small vessels are getting affected, and they are going to land into either clot-getting pain or non-healing ulcers. And this is one condition. So here there is almost SFA completely occluded, and post balloon angioplasty you can see the clear appearance of flow here. And this is one case I did in Anu. So this patient presented with non-healing ulcer over the foot. So diseased PTA and very less flow in ankle, and there is mid ATA occlusion also. Sorry for the non-clear images. So post balloon angioplasty, the 3 vessel runoff is very beautiful, and in the ankle also flow is improved. And this is another condition. So patient presented with severe low backache and clot getting pain. So on evaluation, it's bilateral long iliac occlusions from almost aorta to external iliac artery, common femoral artery origin. So we did kissing stenting, bilateral iliac angioplasty, and patient is doing well, and he is still on follow up. So this is another condition post THR. You can see the implant. So there is large pseudoaneurysm from the profunda femoris artery. So this case we did in fellowship. So we did jail block from profunda femoris artery, and you can see clear disappearance of vascular blush here. So these are the and aortic interventions, EOR and TOR, endovascular aneurysmal repair or thoracic endovascular aneurysmal repair, and due to hypertension, aortic dissection is one of the medical or surgical emergency, and abdominal aortic aneurysm also, it's like volcano kind, you cannot say when it is going to blow out. So EOR and TOR, these major procedures also we are going to do with local anesthesia and skin incisions. So this dilated part is aneurysm, and this is the landed graft deployment post procedure. So this is another image, thoracic dissection. So you can see the flap here. So type B dissection, this is type B dissection, and this is the image, this is the graft deployment just from distal to subclavian artery origin. So these are the 3 vessel runoff from arch of aorta, and this is the deployed graft. So next another common condition is DVT. So in normal first we are also used to follow conservative approach for initial 3 to 4 days, but once the patient is not responding or limb is going to threaten, then we used to treat aggressively, and with the latest advancement in hardware and all, now we are doing very aggressively actually. So if the thrombus is extended into common iliacs or even into sometimes IVC, so we used to deploy from IVC filter, and then we will proceed for mechanical thrombectomy. So this is the one case, this is the deployed IVC filter here. So we used to deploy from below the infrarenal portion. So this is another condition. So normal image, you can you have to see the clear iliac flow, iliac vein flow. So this is 30-year male presented to me 5 months back. So severe swelling and pain. So when CT venogram there is a compression of the common iliac vein by common iliac artery. So this is the condition we used to call May-Turner syndrome. So so we deployed the IVC filter and later catheter directed thrombolysis through the we took the popliteal vein approach and we enter into up to IVC and then did catheter directed thrombolysis and then catheter directed thrombectomy and mechanical thrombectomy, and there is narrowing at iliac vein here. So we did balloon angioplasty to improve the stenosis and the flow established beautifully. So this patient is also doing well, and this is the removed thrombus. So another common one is AV malformation. So slow venous malformations with no major arterial or venous supply. We used to deal with sclerotherapy. Sclerotherapy will give beautiful results, and if the venous if the size of the lesion is very large, we used to divide it into 2 to 3 sessions depending on the size of the lesion. And this is young female, 20 years female, and slow malformation in leg. So sclerotherapy images, and this is a post sclerotherapy, disappearance of venous channels, and this patient is also doing well. So these are the procedures all and done under local anesthesia and daycare procedure basis only. And next coming to gynecology. So in gynecology, common conditions like fibroid embolization, postpartum hemorrhage management, and pelvic tumor embolizations or AV malformation embolizations. So the basic common procedure is uterine artery embolization. So for surgically unfit candidates with large fibroids or postpartum hemorrhage, either may be due to some pseudoaneurysm or some pelvic AV malformation, we used to do uterine artery embolization. So this is one condition. So this is the blush. So we took bilateral iliac arteries access and bilateral uterine artery selective cannulation, and we will embolize both uterine arteries selectively. And this is the fibroid blush. This is after embolization. So this is the large fibroid. This one is large fibroid after 6 months follow up. So this is the almost not turned out to be negative. And this is one case, 23-year female, postpartum, bleeding PV, intermittent spotting. So CT angio revealed pseudoaneurysms. So these are some selective after selective cannulation. This is the pseudoaneurysms. So we did glue embolization, super selective cannulation and glue injection, and post embolization there is no pseudoaneurysm here. So this is another case, interesting one. So cervical cancer patient, post radiotherapy, severe cervical stenosis, presented with severe abdominal pain. So CECT they mentioned some cystic lesion in the abdomen. So so this is actually distended uterus. So due to severe cervical stenosis, the fluid got accumulated and patient presented with severe abdominal pain. This is called hydrometra. So through transcervical approach, we did balloon angioplasty near the cervix actually. So to pass the guide wire and to pass the pigtail. So after serial dilatations and degrading of the dilatation size, so patient entire hydrometer is cleared and stenosis is also opened. So this last image is the post follow up. So this is the first image and this is the last image. And fetal interventions. So common interventions like amniocentesis, coronaquilla sampling, and another one is fetal reduction. In this case, this one is triplet pregnancy. So in order to reduce the fetus selectively, so we selectively entered one of the fetal heart and did the fetal demise, and this patient delivered successfully in at Anumai Baby Hospital only. So next come to GI, gastrointestinal. So biliary interventions, mostly PTBDs and percutaneous transbiliary drainage. So with either combined with internal external drains or metallic stents or self-expandable metallic stents. So PTBD is one of the procedure to relieve the biliary obstruction either due to mostly we did in proximal obstruction, that is especially hilar cholangiocarcinomas. So in this we selectively approach either from right or left hepatic duct and will cross the obstruction, and then will place a tube or stent, depends on the further plan. If it is completely inoperable, we used to deploy metallic stents for permanent solution. If it is acute condition, or if it is, I mean, if they are going to operate, we used to place internal external drains only. So this is one condition. So there is severe stricture, cross the obstruction, so small balloon dilatation because catheter is not tracking, and post internal external drain. So internal external. So the purpose of the internal external drain is to cross the obstruction and to establish the normal pathway of bile flow, that is into duodenum. And hilar reconstruction. So this is some types of cholangiocarcinoma and hilar obstruction levels. So these are the some cholangiocarcinoma bilateral type 4 block. So this is CT image showing bilateral IHBRD. So this is the deployed stents into duodenum. This is the level of obstruction. And percutaneous cholecystostomy, this is simple procedure where we perforate the gallbladder in case of severe acute or sepsis patients where they are not going to operate immediately. To relieve immediate sepsis, percutaneous cholecystostomy is the procedure we used to do under ultrasound guidance only. And post cholecystectomy, there will be some biliary obstruction because of anastomotic stricture. In those conditions, we will do serial dilations through again PTBD procedure only. These are some case images. So, and pancreatitis, another common condition, pancreatitis. So pancreatitis where there are severe, large collections like walled-off necrosis or pseudocyst. We used to do percutaneous therapeutic, aspirations and large bore, wide bore catheters to avoid major surgical procedure like necrosectomy. We used to place 20, 24, sometimes 32 French Thalquick catheters also. So these will give beautiful results, without any surgical intervention. If we do it proper under image guidance, if we do it with wide bore catheters, maybe there will be a need of some upsize of catheters later, but we will avoid major surgical procedures like pancreatic necrosectomy. So these are some cases. So 32 French, 22, 32 and 18 to 24, and these are some images post procedure, almost resolution of collections. This is the first image. There are large collections around the pancreas here, and this is the third image where almost nil post procedure complete resolution of collections. And secondary vascular complications like pseudoaneurysms from splenic artery or gastroduodenal artery, which leads to hematemesis or GI bleed. We used to do coil embolizations. This is one condition where hepatic artery pseudoaneurysm, and this is selective cannulation, and this is the GDI artery coiling for the pseudoaneurysm. And another one is hepatic artery pseudoaneurysm, either due to surgical intervention or some oncological thing. Hepatic artery pseudoaneurysm is also common condition. So this is the aneurysmal outpouching, and this is the post procedure coiling. And portal hypertension. So TIPS is the one of the major intervention for the portal hypertension to reduce the portal vein pressure gradient. So TIPS we approach from IVC, and to reduce the portal vein pressure, we connect the portal vein to systemic circulation so that pressure will be reduced. So I am not going to detail with TIPS. And varix embolization is another emergency, especially in fundal varices or gastric varices. So patient will present with massive hematemesis. So we do BRTO, that is balloon occluded retrograde transvenous obliteration of varices. So here due to splenorenal shunt, there will be a massive fundal varices which leads to massive bleeding. So here we selectively ablate the fundal varices which are actually bleeding. So this is the one CT image So pre and post, these are the pre-procedure varices, and this is the post-procedure glucast near fundal varices. So pre and post, these are the collaterals, and disappearance of collaterals post BRTO. This is also one, sometimes it can be life saving. So next, nephrology. Nephrology, mainly my area of concentration is fistuloplasty and central venous angioplasty, renal artery stenosis. So dialysis access, so generally simple dialysis access most of the times now nephrologists themselves doing, but where actually we come means due to multiple catheterizations, due to multiple venous multiple venous access, the access can be blocked. I mean, due to either thrombus, the access can be blocked. There we comes into role. So we did balloon angioplasty in case of thrombus or severe stenosis. Then we will put a catheter for the long term access, and complex perm cath access and venous access we used to do tunneled line perm caths. So this is the normal perm cath image. And venoplasty, due to central venous stenosis or obstruction, patient presents with facial and arm swelling. So central venous stenosis, until otherwise we relieve central venous obstruction, either dialysis also won't happen effectively, and patient won't improve symptomatically. So this is another procedure which will give immediate and effective results. So these are the some cases. So there is no flow into SVC. This is the block and cross balloon. So post procedure, disappearance of collaterals and flow established into SVC. So and another one is fistuloplasty, simple procedure to save the AV fistula. So AV fistula issues are very common, either decreased flow rates or thrombus or occlusion of the AV fistulas are very common. So fistula should be saved because dialysis won't happen effectively through catheters, and the catheters are always prone for infection. So fistula should be saved. So fistuloplasty is some small simple procedure. So these are the some images. So this is the arterial end, this is the venous end. So this is the actual fistula, but the fistula site is stenosed. So balloon angioplasty and post procedure opened fistula nicely. And in urology, embolization for uncontrolled hematuria, post PCNL bleeds, renal artery embolizations are sometimes pre-procedure for RCC. Pre-surgical used to do pre-op embolizations and renal artery stentings, PCNs, DJ stentings, where cystoscope, I mean through retrograde approach scope. So we used to come antegrade approach, and we used to do DJ stenting in case of difficult access from cystoscopy. So these are the common procedures we used to do in urology. And another one is varicocele embolization, and for RCC, radiofrequency ablation for single solitary less than 3 centimeters lesion. RFA is very effective and beautiful procedure which can give almost similar results to comparatively surgery. So some cases, percutaneous nephrostomy. So idea is to either divert the obstruction or relieve the obstruction. So to relieve the obstruction and urinary diversion in case of hemorrhagic cystitis and trauma, and access for endourological procedure, that is dilatation and stenting of ureter. So PCN is one procedure. So we took the lower pole axis, nephrogram and stent placement or drain placement, and embolization for hematuria. So this is the one condition where there is a pseudoaneurysm from renal artery, and post procedure coils deployed, and prostatic artery embolization for BPH. This is one of the emerging procedure. So benign prostatic hypertrophy, common problem in once we cross some 50s or 60s, and prostatic artery embolization will give similar results, where we used to selectively cannulate prostatic arteries. Those are very small arteries, and we will cut the blood supply to the prostate so that gland will shrink. So this is another effective and novel technique. Now it is in emerging practice in metros to avoid surgery for prostates. And hemoptysis, so India TB burden is very high, and still we are seeing post TB complications either in the form of hemoptysis or some pot spine something. And bronchial artery embolization is another effective procedure to reduce the hemoptysis, and it is sometimes it can be life saving also. So this is one effect, upper lobe affect, left side upper lobe affected, and these are some case images. So this is the actual blush from either left feeding artery from subclavian artery. So this is the actual blush before pre-embolization, and this is the post-embolization, the blush is gone. And this is another case, vascular blush from feeding artery, bronchial artery from aorta, and post procedure blush is gone. So so this concludes main vascular procedures system wise. Next come to ablations. So ablations are basic principle is through some form of energy we should kill cancer tissue. So different energy forms like RFA, I mean radio frequency ablation, microwave ablation, and cryo ablation, and radio frequency ablation for lung nodules. So it can be sometimes curative or palliative for lung cancers. These are the some images. So this is the deployed probe for the single solitary lesion, and these are the electrodes deployed. And in bone, especially osteoid osteoma, radio frequency ablation is another effective procedure. And radio frequency ablation of parathyroid adenoma, single solitary parathyroid adenomas, radio frequency ablation will give beautiful results. So the effect will commence from with 3 days post ablation. So it will confirm by serum calcium levels return to normal within 72 hours post treatment. And radio frequency for adrenal mets. So this is the one lesion, and these are some case images, 3D reconstruction case images, radio frequency ablation for adrenal mets. And I just want to make a special note on hepatocellular carcinoma because it's relatively common. So only 10 to 15% cases are eligible for resection, and because contraindications for resection are extrahepatic disease, insufficiency, and multifocal disease, tumor in distant spread, and comorbid conditions. So most of the times by the patient comes to us, he or she goes into a non-resecting stage. So regional or local treatment, I mean like ablations like microwave or radio frequency ablation, or embolization techniques like transarterial chemoembolization or transarterial radioembolization. So these will give beautiful survival rates, and 1 year survival in 1 year survival is almost 95 to 96% post effective test actually. So some case images, this is the pre-procedure, and post procedure there is no enhancement in the contrast CT. Here pre-procedure some heterogeneous enhancement in HCC, post procedure almost entire tissues in necrosis, and almost after 8 months also there is no enhancing areas after ablation. And the goals of ablation is, I mean, equivalent to resection in survival and recurrence, and sometimes it will be used as bridging therapy for awaiting transplant, and sometimes as I told palliation, and sometimes it will convert unresectable to resectable disease. And percutaneous ethanol injection for very small injection, sometimes for hidatids we used to do pair treatment, percutaneous ethanol injections, and TACE. So hepatic chemoembolization, that is transarterial chemoembolization. So in this we took femoral artery puncture through, and then we will go selectively or super selectively into liver cancer, I mean where into artery which exactly supplies the liver cancer, and we used to deliver chemotherapeutic drugs. That we commonly used drugs are doxorubicin and cisplatin. So TACE we can give, we can do in multiple sessions also. So for large tumors, sometimes 10 to 11 centimeter tumors, we used to do 2 to 3 sessions. And recently, I mean the combination therapy like TACE with ablation or ablation with TACE, those are giving very good results actually. So TACE is another common procedure, and we can do here. We don't need to run for now metros also. So this is some case images again. This is the pre-procedure CECT image enhancing part. So this is the blush from the tumor. This is after lipiodal injection, lipiodal with doxorubicin combination. So this is the post completion procedure. You can see the clear uptake of doxorubicin particles and lipidol here. So this is just HCC now recent updates and all. So treatment for a small HCC. So to conclude, so almost more I already told you 90% of the procedures done under local anesthesia and daycare procedure, and patient can go home same day, and either for diagnosis or for treatment, like any for any small targets or any collections, any bleeding, any lines like Pomcats, PICC lines, Hickman lines. PICC lines or Hickman lines are delivery lines for bone cancer patients especially. So IR plays a definite role, and it is a very evolving and playing significant role in upcoming modern medicine. So with this I would like to conclude my topic here.